Welcome to Eye Contact. I'm Sean Henahan. How can we get the best results for our IOL patients? Today I'm discussing that question with Dr. Nino Hirnschall. Welcome, Doctor.
Thanks for having me.
Much has changed in recent years in the area of biometry. What are we doing in that area that can optimize outcomes for our cataract surgery patients?
Well, I think one of the very big changes was the optical biometry. And by chance, exactly today, 20 years ago, that was established and launched the first time. And I think since then we went a long way. So from PCI technology, now we use swept source OCT technology, which means you get even more accurate. So I think that's one of the steps that we really did within the last decades maybe as well.
Now, what about intraoperative barometry? This is more recent, and how does that fit in with what we were already doing?
So I think it's quite a tricky question to talk about intraoperative barometry, because when you have a look at barometry itself, it's very sensitive to changes. So anything you do to the cornea or to the eyelids, let's say you use the lid speculum or you drape, of course, the draping at the beginning, any kind of OVD you use in the eye, any kind of teardrops you use on the eye, OVDs you use on the eye, all that has a very, very big influence on the outcome. So I think nowadays, I'm not very convinced that intraoperative barometry itself, just as a standalone complex, will give you the results for refractive outcome as you would like it. I think in combination with biometry, a lot of big data collection, it might be very useful.
Are there some particular cases where you would say, oh, I need to do that?
I think for patients after refractive surgery, it might be very beneficial. There are also some papers out there that suggest that as well.
So dysphotopsias are still one of the leading causes of patient dissatisfaction following cataract surgery, particularly with multifocals. Are we making any headway in that area?
Definitely. I mean, there's some papers out there by Samuel Muscat, for example, Jack Holliday, and they showed different kind of principles that could lead to dysphotopsia, negative dysphotopsia. I think that a lot of things have to be researched so far for these topics, and there are two big ESCRS studies going on. One by Juan Murta, and basically he's doing functional MRI technology he's using just to get a better idea about what patients really perceive when they have negative dysphotopsia and how that changes over time, so neuroadaptation, all these things. I think we have a lot to learn in this topic. And now there's by Bedecker, there's another big ESCRS project going on, and he also does a lot of ray tracing and getting a better understanding of the core of the problem of negative dysphotopsia.
This does seem to be something associated with the multifocals.
Yes, I think for positive dysphotopsia, definitely, that's a big problem. I think we really have to distinguish both of these concepts. The positive dysphotopsia that we have also for EDOF lenses and for multifocal lenses, and then a negative dysphotopsia that we have basically in all the lenses that we have.
Right.
And yeah, and some
that's a good point. It's not exclusive to multifocals.
It is not, no, exactly, yeah. Mm-hmm.
What do you see in the pipeline that could improve patient outcomes in terms of pre-op evaluation?
Well, one of them is intraoperative OCT technology, I assume. I mean, it's something we are working on, so I'm completely biased on that, but still want to talk about it a little bit. And the concept behind this is that we just measure the patient intraoperatively after the phaco, so in the aphakic state. And then the idea is to predict, using the position of the anterior lens capsule and the cornea, just the distance between those of them, predicting the position of the lens after surgery. Because that makes sense, because in the preoperative state, you have a very thick lens in the eye, obviously 4-5 millimeters. And then after surgery, you have a lens which is usually less than 1 millimeter in thickness. So there's a lot of a shift that you can't really predict properly. And all these conventional formulae just try to predict it using different parameters. But with intraoperative OCT technology, you get a better understanding of how the capsular bag looks like in the aphakic state and then also in the pseudophakic state. And that will help a little bit, I guess.
That helps with the effective lens position.
Yes, it does. So we published some papers on that. Again, I'm completely biased, but we just showed definitely in 205 eyes in one study and now in 70 eyes with a bit more sophisticated approach to get it better done. And another thing that I think we should talk about is maybe RIQM, which is a relatively novel concept of just not using a number for calculation of a lens or a toric lens as well, but using an image-based system. Because nowadays we have so many patients after refractive surgery, any kind of irregularities of the cornea, and then we still do simple number crunching. But for these cases, we really have to figure out what's the best image on the retina could be with any kind of lens, and do a kind of ray tracing, and an image-based concept would help us a lot in these patients, I guess.
Interesting. Well, thank you for speaking with us.
Thanks a lot.
And thank you for joining us. For more information, please visit us at eurotimes.org.